to present this in front of you all because acute MI, the pharmacoinvasive strategy, is order of the day which I feel is particularly suitable for our Indian subcontinent, where the laboratory cath lab facilities are straight away not available in many other places, though level 2 cities like even some of the periphery have developing cath labs, but still we are far way to go. So particularly a country like India, the pharmacoinvasive strategy probably is a thing, and in future you could get more and more trials. We just had one NEJM article published, and we wanted to see whether this concept could work in our country. And there are already some initiatives which are coming up in Chennai and other places, but I am very happy to say that MQ Relaxing has come forward to help with the trial. The FACS Foundation, the research activity, one of it, we thought we should take care of this, which is very much essential. We do see a lot of young MI patients. So this is done by FACS Foundation, then extensive collaboration from Maxim MQ. We thank them for this. And next coming 5-10 minutes, what I would show briefly is how each patient is being triaged and taken. This slide brings best wishes from Continent Hospital. This is the FACS Foundation, which Dr. Ravi was mentioning, which acts as central coordination for all this research activity. The pharmacoinvasive strategy is basically what we are trying to see whether thrombolytic therapy with tenecteplase in a pre-hospital or a hospital phase, or as like a smaller similar referral centers, can be given, followed by when they're shifted for angiogram followed by PCI. We basically want to see the primary objectives of this trial is to assess the outcomes of pre-hospital thrombolysis or thrombolysis in a smaller peripheral referral center than in patients with STEMI. That's the primary objective, because previously people used to say that is not possible in our country, but with the Elaxim tenecteplase, which is more relatively easily, which can be administered to patients, I think it is easily done, possible in our place, which is trial is highlighting upon. The secondary objectives are to assess and compare the safety and efficacy of pre-hospital thrombolysis, and we also try to see some patients who directly come to one of these referral centers where the PCI is also available, how do they fare, and though it is not a direct randomized comparison, but it's what is called as cluster randomization, and we try to see the group of which are directly taken for primary PCI compared to those which are being shifted after thrombolysis, how any difference in outcomes. The primary endpoints is basically we're interested to see the patency of coronary arteries when you take these procedures, and ST segment resolution, left ventricular function, all-cause mortality, and recurrent MIs and cardiac shock within 30 days if they're happening. Secondary endpoints are like any other thrombolytic thera, like incidence of stroke, bleeding, and any complications of MI like pulmonary edema, arrhythmia, and some of the serious clinical events. And one more thing we also want to highlight is the hospital stay could significantly come down. Such procedures is offered early. Initially, we plan to have about 100 patients with chest pain visiting the selected clinics and nursing homes, and meeting the eligibility criteria in the study. The inclusion criteria are like standard acute MI criteria. The patients within 6 hours of onset of chest pain with ST segment elevation, in the standard 1 mm in 2 limb leads or 2 mm in contiguous leads, and patient willing to participate in the study. Exclusion criteria are again the standard exclusion criteria for thrombolytic therapy, which is the high blood pressure, bleeding disorder, recent stroke, and cardiac shocks obviously cannot be included. The randomization is basically pre-hospital. The pre-hospital thrombolysis, basically when the patient comes to this, aspirin and clopidogrel is given along with IV tenecteplase, 0.5 milligrams per kg. Most of the patients we have seen are also thin in body weight, may not be requiring 40 mg also, and they end up giving 30 milligrams of tenecteplase. The PCI Protocol is again aspirin, clopidogrel, and the standard practices of thrombectomy and stenting are followed as per the institutional practices. LV functions we plan to assess at 5th day and at 6 months, and in some patients in which cardiac MRI is possible also being planned, because that is probably a more better way of assessment. And the PCI sites are Continental Hospital, Care Hospital. Some patients who are not able to come here will be also seen in Usman General Hospital. We also have now cath lab intervention facilities where my colleague Dr. Ravindra Reddy is there in Pratima Medical College, Karimnagar, and we also help them. So that could be also one of the PCI sites. The referral centers, I'm extremely thankful to all the physician colleagues across who are helping in study, and some of them are sitting in the audience. Dr. Lakshminarayana from Karimnagar, Dr. Mohan Rao, Dr. Ravindra Reddy, again, he works as both ends, Dr. Chandra Reddy from Siddipet, Ramchandra Rao and Kot Reddy. My extreme profound thanks to all of them for being part of it, and how we want to follow up these patients is mentioned here, 1 month, 6 months and 1 year. And if you see, this is what gives a lot of satisfaction when you are working on. This is the ECG which came on 4th April at that particular time which is mentioned. We thought that lymph lead is not positioned correctly. We asked them to repeat ECG. With the times which are mentioned there, it is there. Then we wanted again next ECG which came with proper leads. Again, it shows classical inferior wall MI. We give clearance to thrombolysis. How it works is the ECGs now they are linked to with a central server, and the thing comes onto our iPhones, and then we immediately check the ECG and give clearance for thrombolysis. And then once we go say thrombolyze with no contraindications, then the physicians in the periphery give tenecteplase, which is quite simply to be given. And then this is a thing where the STs have regressed after thrombolysis. There is another patient which is more dramatic, 1st of March, 542. If you see here, it is inferior wall MI, AV block. Patient was having blood pressure, low blood pressure. In the previous era, we were worried to give streptokinase. But once I see it, seeing this, we have cleared it for tenecteplase. You note the timings also there, 1542. Then here, once the thrombolytic therapy is given, once the artery flow is established, then the heart rate's improved, and then again, patient significantly improved after this. Then some of these lives could be also saved like this. And I should be also mentioning Kanchan of Laxim. She'll be also behind us. Suppose one ECG comes, they also get a mail there, then she'll be closely following it up so as to not to lose time. So I'm extremely thankful for the active interest she's taking for the conduction of this trial. As of now, we have enrolled 33 patients, and thrombolytic therapy is given. Then angiograms are done in about 28 patients. Some of them we are missing. Then PCI was required in about 12 patients. And the average window period of thrombolysis, which I would say from the onset of pain to thrombolysis, is again quite commendable in our circumstances, 4 hours. The average PCI time, because depending upon the stability of patients, you are allowed to shift patients right immediately or within 24 hours. The average time which was done in this number of 12 patients were about 10. Angiograms done was 28 patients. We are very heartening to note that only but for one patient, rest of all the patients' arteries were open. And PTCA was needed only in about 12 patients because the residual critical disease was there in 2 patients, but recanalized appearance was seen in about 8 patients. And PTCA was done in 12 patients. 1 patient had tuberculosis disease, stabilized later, and the CABG was done. Then 2 patients had died out of these 33, and the one was because of right ventricular MI, second was cardiogenic shock, which obviously we had a QRV pattern before, and thrombolytic therapy was given, but still patient further. Initially he was not, but gradually progressed to cardiogenic shock, and he couldn't save that patient. I would like to say out of this significant number of patients, my colleague Dr. Ravindra Reddy is sitting here, is extremely active, and most of the patients are contributed from there, and with few of them coming from Siddipet and other centers in Karimnagar. I'm extremely thankful to him for his active interest. The data compilation, because I was occupied, busy with most of the conference work, he is instrumental in collecting the data, and I'm just presenting that, the analysis of it. Then coming to the last conclusion slide, I am very happy to say that in Indian subsets where people think that we are not geared up, tenecteplase can be safely given in clinics and peripheral nursing home setups, and the patients can be transferred again. And the ECG, only thing is it has to be given right patients. That we are able to do it with the help of technology. We cross-check whether it is correct MI or not and give clearance. Then giving Erexim tenecteplase is now simple because it doesn't require too much of monitoring. And most of the patients did well. And when the patients are shifted further, we were very happy to note that but for one patient, most of the patients' arteries flow was established, though angioplasty was required in some subset of patients. But even if your heart can get a little of it, blood supply could improve further. We are going on to analyze further of LV function data, which probably we'll be able to highlight and complete the study, and will present to you probably in next ACVS. Thank you very much for your patience here.